Dear colleagues, this is a soft cataract done in subconscious anesthesia and is done with the left hand, not non-dominating hand. We have to train I believe, we have to train our hands to be able to do surgeries, and we should be able to do with both hands surgery depending on the eye. We can train to do the left eye with the left hand and the right eye with the right hand, using the phaco emulsification probe into the hand that it's on the temporal side of the patient. And with practice, that's not big deal. Of course, you're not going to be able to do exactly the same way with the non-dominated hand, the way you operate with dominating hand, but still we can be able to manage decently the cataract even with a non-dominated hand. This sometimes we have deep-setted eyes, and you're not always very keen to stay in the temporal side. You want to operate on the patient head, so training your hand to do the same maneuvers, training your hands to be able to do the same maneuvers with both hands, it's very handful. It's basically a mindset training more than it is your hand training. It's very soft cataract in this case. I'm doing horizontal chop. The rotation is very easy to do using the dominated hand. It's the easiest. That's very easy to have the dominated hand do the chopping maneuvers and having the nucleus rotating. Having these chops on the periphery, using the chopper to do the chops, it's the nucleus is very soft and it's cracking just in the periphery. It's like flower petals. But even though even in these cases you can do the phaco emulsification nicely. I got presented with an opportunity to take care of the hardcore nucleus. It's not that hard, but it's harder. It's thicker than the periphery. It's a little bit harder than nucleus in the middle. So that's was lifting up a little bit from the bag, and I took advantage of this opportunity and emulsified the core of the nucleus, and that got the job easier. Now taking care of the epinucleus, rotating and aspirating, it's no big deal. It's just we have to take time and not rush to this procedure, especially if we do it with a non-dominated hand. We have to be patient with us and gentle. The iris should stay in the place. That's a good idea. And gently pressing the foot switch, it's taking care of the last part of the epinucleus, and it's very easy to aspirate it. It's a very small piece of epinucleus that's stuck on the viscoelastic, and using the AC maintainer into the main incision, I'm aspirating the last part of the cortex through the paracentesis using this aspiration cannula, washing out the cortex with the last remnants of epinucleus, and at the end of the phacoemulsification we have a clean bag to inject the IOL into it. The part of the aspiration of the cortex is done with, as usual, with using both hands on the 5 ml syringe, injecting the IOL the same way with the non-dominated hand through the incision that's on the left side, and this is a hydrophobic IOL. It's unfolding a little bit faulty, but using the chopper I'm able to rotating a little bit and place the trailing haptic also inside the bag, cleaning up the last part of the viscoelastic, and that's the end of the case. Thank you for your attention. Hope this will help you in your practice also.